I mean, it's a known fact that lockdown buys us time, but it is in no way a solution to anything. And what we have to do is focus on actions. And I think, Sir Patrick and Professor Whitty, that you're both contradicting yourself when it comes to testing and tracing and isolating. And let me just explain what I mean. So you've spoken a lot about the R rate and trying to get the R rate below 1. Well, we know that once you start testing people, if you don't get the results back within 24 to 72 hours, that has an effect on the R rate. So you can't talk about the R rate without talking about the effect in testing and getting the results back on time. Am I correct in my thinking, or am I wrong in my thinking?
Well, I think you're probably bringing together two separate important points. I mean, the first one is you are absolutely right that to reduce R, test and trace systems need to get the results back as fast as possible. The faster they do, the bigger the effect on R. That's a critical part of it. And actually, one of the reasons that I, amongst others, am keen not to always have test and trace being asked to do yet more things is that really this shortening of the time is a critical part of it. But the calculation of R does not itself depend on the length of time. That depends on the number of incident cases over over a period of time. So I think the point you make is a perfectly reasonable one, but it doesn't affect the R in the terms of how you calculate it. But we must try and reduce those times because that's how test and trace has its biggest impact.
Okay, so in the short time, thank you for that. So in the short time, it will have an effect because you'll know the infection rate. Now, as we know, in the summer, when we went into national lockdown, there was around 100,000 people showing symptoms of COVID. During the winter, that number will rise exponentially to 500,000 people a day will show symptoms of COVID. They may have COVID, they may have flu, they may have something else. So that therefore surely means we need to ramp up our testing capacity to 500,000 tests a day. How close are we to achieving that?
Well, I'm very cautious about getting into the business of trying to kind of say what proportion of tests are. There's tests available, there's tests done on individual people. They're all slightly different calculations. But the capacity to do testing for people who are symptomatic is substantially greater now than it was at the beginning of this month. But I'm not going to put an exact number on it because I'm not the right person to answer that question.
Who is the right person to answer?
Test and trace are the people who actually have the data on that.
The Dido Harding. So are you in any way in discussions with them? Do you in any way know how close we are to achieving what we actually need in order for you to be able to model correctly in regards to what we need going into winter? Because I'm sure you're aware of the frustration of the public. You have both said previously that in order for us to combat and control the virus, we need the public to comply. Now, as you know, the public are very frustrated. These questions are important for the public to understand what is going on and why. So what, in your estimation, how close do you think we are to achieving the capacity that we need? And not the capacity, because you can say capacity means nothing. We need to know numbers. 500,000 people will have COVID-like tests every day. How close are we to achieving that in regards to testing?
So I think what I'm going to, I'm trying to answer your question. I hope helpfully. There's varying indications for testing, and the point you're making completely rightly is that as we go into winter and autumn, we're likely to have more people who have symptoms compatible with COVID who don't have COVID, but who still need to be tested. I hope I'm paraphrasing you correctly. And part of the key reason to increase capacity for test and trace, in my opinion, has been exactly to achieve the point that you've just raised. But there are obviously, and so, my hope and expectation, actually, is that test and trace will have the capacity to test people who are symptomatic through the winter period. That is my expectation. There are also some very clear indications that I think everybody agrees on in terms of other uses. There's clinical uses in hospital, obviously, there's testing in care homes and a variety of other indications. But there's also a lot of additional things which people think of which could be used testing could be used for, which include, as you know, there was an asymptomatic mass testing pilot launched yesterday in Liverpool. There are people talking about doing much more widespread testing of health and social care workers, and Mr Hunt on the Health and Safety Committee has made a very strong right point on this, and so on. It depends really what the denominator is you're talking about. But in terms of the people who got symptoms, my expectation is that Test and Trace, who have, as I say, done a really good job in this area, should have the capacity in terms of numbers of tests to be able to do that.
Thank you. I mean, Professor Whitty, you have said in February that SAGE recommended that there was an increase in testing, and we also know that testing people as symptomatic just isn't good enough, because we've been told by SAGE if we only test people as symptomatic, we miss 70% of people who actually have the virus. But I'll just ask you another question. Did shielding, in the summer when we went into national lockdown, did the shielding of vulnerable people help to save lives?
I think what we thought, so we haven't had a really clear answer to, there were definite benefits and definite disbenefits of shielding. The benefits were reducing the risk that people got COVID. The downside, but the trouble about that is there wasn't a denominator, because you took all the people who were at risk out into the shielding group. The downsides of it were also clear, which was an increase of loneliness, an increase of, in some cases, probably mental health issues and so on. And trying to work out the balance between those, our impressionistic view is that shielding was useful, but should be a less strict version of shielding in the next phase. To allow people a little bit more, particularly time outdoors and so on, because actually there was this real worry that people were feeling trapped in their houses and all the downsides that went with that. So there has been an adaptation of that, and we're also intending to change over time the group of people who are in the shielding list, and there's been something published in the BMJ a couple of weeks ago which explains how we're going to do that, because the exact risk factors that led to the shielding list were generated at a stage we understood much less about COVID than we do now. We still are learning a huge amount more, and we will know more in another 6 months. But at the moment, we think we can actually change that. The biggest change being quite a much very high proportion of the children who are shielded. The view was the risk is not sufficient to justify the significant downsides on that. But there have been other important changes with the shielding. So it's an important question you've asked.